Well, Jeffrey, it's September 24th, 2020. We're in the midst of presidential election. I think that's dominating everybody's agenda, as well as the coronavirus epidemic. And HIV/AIDS is kind of in the background. Still a significant problem in the United States. Just doesn't get a lot of attention. Well, I think there are a lot of comparisons, a lot of similarities between the early days of COVID-19 and HIV. We're dealing in both cases with mystery at the very beginning, something that seems to come out of left field and about which very little is known, and which both of which instill a lot of fear in the public. Both cause a lot of worry, a lot of misunderstanding, misinformation, and people want clarity and want to go on with their lives, but here something new is stalking them. And it reminds me of the early days of AIDS and HIV, where there were so little facts and so little information, and governments that were paralyzed for different reasons. Well, immunology is the study of the immune system, which is kind of ill-defined. It's scattered around the body. I mean, we have immune cells in our mouths and in our eyes, and we have immune cells in our lymph glands and in a big organ in the abdomen called the spleen. But it really permeates the entire body, so it's not as easy to localize as the heart or the brain. There are a number of basic arms of the immune system, probably 5, 6, 7, and a lot of chemical molecules that communicate between the cells. But the basics are that there are B cells that produce gamma globulin. And then there are T cells that help B cells do this, and they also attack virally infected cells, so-called cytotoxic or killer cells. And the so-called helper cells have a marker on their surface called CD4. And they're the helper T cells that help B cells make gamma globulin. But they also help the cytotoxic or killer T cells in their work to defend the body against viruses and parasites and fungal infections, invaders. So I was at UCLA in the Department of Medicine, Internal Medicine, the Division of Allergy and Clinical Immunology, starting in June 1980. And I saw my very first patient with unexplained fevers and weight loss in January 1981.
Do you remember anything about this man that you saw, this first patient?
Sure, I remember his name, I remember what he looked like. His initials were MP. He was quite thin, had lost weight. He had cheekbone implants because he was a model, very openly gay, joked about it with us. And you have to remember things were different in 1981. There wasn't as much give and take between much understanding between the straight community and gay people. It's a different time. My postdoctoral fellow and I were making rounds, and we come to his room on the 6th floor or the 4th floor of UCLA Medical Center, and he's on the phone with a friend. And at that point, he utters that remark. "Bruce, the doctors here tell me I am one sick queen," and he's laughing. That first patient, his attitude toward his illness was sort of flip. In other words, hey, the doctors say I have this, they say that I'm sick, but there was no sense that this was going to be a fatal illness for him. He lived about 6 months after diagnosis, and he died with Kaposi sarcoma and pneumocystis pneumonia. You just don't see previously healthy people getting so sick and and you're unable to establish a diagnosis quickly. That's what was striking. It was truly a mystery. Pneumocystis is a pneumonia which we thought was due to a parasite, but now it's been reclassified as a fungus, and it only occurs in people who are immune compromised. And we had figured out early on that this patient had very few CD4 helper cells, the critical cell of the immune system that is important for organizing defenses. Kaposi sarcoma, which he also had, was a skin cancer primarily, purple or violet patches on the skin, sometimes on the face, and very distressing to patients. But it also involved in these patients' internal organs. It could occur in the lungs and the gastrointestinal tract, and was kind of an unknown in terms of how to treat it very early on. There was really no specific chemotherapy for it when we first started seeing it in the early 80s. People were dying in awful ways. We as doctors were standing by and basically hand-holding without any resources available other than to treat the infections that patients were getting, and they would come in and out of the hospital. They'd have an episode of pneumocystis and go home for a few weeks and then have another episode of pneumocystis, or come in blind with CMV retinitis, an infection of the retina. And this was tragic. This was horrible, horrible stuff. And we didn't understand it and didn't have the tools to find out more about it. It was a fatal immune deficiency with not much hope of survival beyond a few months to a year. One of the postdoctoral fellows in John Fahey's lab, John was the senior immunologist and whose laboratory had the T-cell tests. A fellow from Missouri. We're standing in the hall one day and said, what are we going to name this? And we thought of a number of different things, and we thought of ACID, acquired cellular immune deficiency. But of course that connoted the 60s and another type of acid. So that didn't work. And then this fellow Bob said, well, why don't we call it GRID, gay-related immune deficiency, which was a mistake. We should have been open to the likelihood that whatever this was, if it was an infectious agent, that it would affect other populations. The attitude toward patients wasn't so good because of the fear involved. People were worried at first that, oh, maybe this is more contagious than it turned out to be. And then they were worried about, even when we knew it was largely blood and sex related, they were worried about handling items in patients' rooms and getting too close to patients. And of course, there's the prejudice against the patients for sexual orientation. Again, this is the early 1980s, when things were not as open and accepting. There was fear and there was prejudice that distanced staff sometimes from taking care of these patients, including some doctors. It was necessary to create units specifically dedicated to treating people with AIDS. And one of those units was started at Sherman Oaks Hospital in the San Fernando Valley by Joel Weissman and Eugene Rogalski and their colleagues. And gay staff gravitated to those units to take care of their own. We turned to industry for funding. We turned to some companies that had immune modulating medications like interferon and other medicines that were touted as having effects on T cells. And so we got small grants from industry to do some of that work. And of course, then came Willie Brown from San Francisco, who was the Speaker of the House. Willie Brown, together with doctors from San Francisco, Marcus Conant primarily, wrote a line item into the state of California budget for research on AIDS to be done at the University of California. And they created something called the University-wide Task Force on AIDS, which administered the funds. Dr. Koop was the Surgeon General of the United States, and he was a pediatric surgeon from Philadelphia. And he was Surgeon General by virtue of his pro-life stance. And he broke with the administration over HIV/AIDS. And his statement ultimately was, "I was the Surgeon General of all the people." And he had a pamphlet sent out to every household in America in English and Spanish, I believe in 1985, telling them all what was known about AIDS and HIV and how to avoid it. Rock Hudson was a famous actor, a very good-looking, tall man, 6'4". Of course, Rock was a gay man, but in the studio system of the time, that wasn't acceptable. So Rock is someone I knew of, who I met around 1984, I want to say, in the office of a Beverly Hills dermatologist who had called me at the medical center at UCLA and said, "Oh, I have somebody I think you need to see, but if he comes to you, the paparazzi may embarrass him. So would you come and see him in my office?" And I did, and met Rock Hudson for the first time, and remarked as we were left alone and I was there to examine him, he sat on an exam table and I had to look up. As you generally be eye to eye with the patient, I had to look up and said, "Oh my, you're tall." And he sort of shrugged his shoulders in a boyish way and said, "Yeah." And he had Kaposi sarcoma, pretty clearly. And I took some blood back to the medical center and we ran his T cells and they were low. And so I sat with him and he said, "Do I have AIDS?" And I said, "Yes, you do." In my meeting with him in this doctor's office, he said, "Well, I want to do the right thing. I've had sex with a number of people. This is sexually transmitted." And what he did was write letters to these people. "You've had sex with someone who has AIDS. Go get tested, get medical care," which he felt was the right thing to do. He wanted to do something about it. And I had a colleague in Paris who was testing a new drug, which had been shown to work against similar viruses in mice. And it was worth a shot. And so Rock was going to Cannes, to the film festival, and he would stop off in Paris to see my colleague Dominique Dormont, who was a military doctor with the French. And Dominique would give him infusions of this drug called HPA-23 in his suite at the Ritz Hotel. And on one of his trips to Paris, Rock was quite ill. I probably should not have let him go. He wanted to go. And he collapsed in the lobby of the Ritz Hotel. He was taken to the American hospital in Paris. A Paris spokesperson, I'm not sure what her association was with him, announced to the world that Rock had AIDS. And this was a pivotal event in the early history of the epidemic, because finally people knew somebody who had AIDS and felt something for that person. And I had conversations on the phone with Pierre Salinger, who was Francophile and had been JFK's press secretary. And he arranged for a 747 to be outfitted with a hospital bed in the first class cabin. And the whole flight was devoted to flying Rock back to the UCLA Medical Center, where he came under my care again. He was gravely ill with pneumocystis pneumonia, and that was treated. He also had a previously undiagnosed cancer in his liver, and it was deemed untreatable because of his diminished immune system. And so he went home to his house in Beverly Hills. We were getting calls from the press, and they were coming in by the handful on little scraps of paper. And I showed this to my chairman, and he said, "You should have a news conference." But before doing that, I sat with him, and I said, "Rock, the press, it was announced in Paris that you have AIDS. The press here are hounding us about your diagnosis. What should I do?" And he said, "I suppose you should tell them if you think it will do some good." And in my heart of hearts, I wanted it to happen, because I knew it would move mountains. I remember chairing the antiviral session at the international conference in 1985, and I saw the first papers on AZT presented from the test tube. I was very impressed with it in the test tube, and then I got involved in clinical trials of AZT. It was a multi-center clinical trial and placebo-controlled, and we did that trial at UCLA and several other medical centers, and the Data Safety Monitoring Board, kind of like the board that's monitoring these vaccine trials to determine efficacy, they said, "Oh, looks like the drug group is doing marginally better in terms of survival than the placebo group," and they stopped the trial. And AZT, the manufacturer, submitted the data to the FDA, and the FDA approved it. As a single drug, it was marginally effective. It was more effective when you used it in combination with later drugs. It's not as if AZT was approved and was ineffective. It was ineffective as a single drug and toxic. I think that was a proof of principle that you could develop a drug, and that a drug actually had come off the shelf somewhere. You could develop a drug that would treat HIV. I think that industry got the message that they could profit and maybe do a good thing by developing medicines for HIV. And so they started looking at similar drugs to AZT, and in 1992 came out with DDI, called Videx, from another company, which worked by the same mechanism as AZT. And then we subsequently did trials combining AZT and Videx, and people did better with two drugs than one. In 1996, people would have to take 10 or 12 pills a day to complete the cocktail. And so that was onerous. And adherence was spotty, and the drugs were toxic. But people started surviving. Their immune system started rebuilding, and people were living longer. And that's when the curve of deaths from AIDS began to take a dive. And we are where we are today as a result of further evolution of that process, new classes of medicines introduced, the research, the fruition, if you will, of all the money spent for HIV/AIDS research.